Hi everyone, and welcome to our next parent training video. So for this one, I want to go over what ABA is. Because we have a lot of new families that have just started with us, and we're getting a lot of questions lately, it seems like, about, hey, my kid just got diagnosed with autism. What are my next steps? So for this presentation, I just want to go over a bit about kind of how those first steps may look, in prescribing hours and that whole intake process, and then get a bit into what ABA is and some general terms and terminology that we will frequently use, so everyone's aware. So ABA, that stands for Applied Behavior Analysis. So this is the scientific study and the analysis of behavior. We focus a lot on the environment and the effects that the environment has on the behaviors that we see out of all persons in general. But ABA is most associated with kiddos who are autistic. Because ABA is proven to be one therapy that is effective in teaching these kiddos appropriate skills that we want them to engage in, while also focus on reducing those maladaptive behaviors that we'd like to see less of. As I said, we focus on those two aspects, on increasing skills that we want the kiddos to have more of, such as communication, social interactions, independence, daily living skills, self-care, and all of that, but also in reducing those maladaptive behaviors, such as, some aggression, property destruction, elopement, negative vocalizations, those type of behaviors that impede them from being successful in their environment. Something with ABA, like other therapies, it is typically funded through insurance. So twofold in that one. It is great because insurance covers it. If the kiddo has that diagnosis of autism, pretty much all insurances will cover some amount of hours of ABA, which is great, but it also means that insurances, they get to control a lot of how that therapy looks because they are the ones who fund it. So it is, like I said, proven to be effective therapy for kiddos on the spectrum. ABA has been around for over 50 years now, well-researched, well-tested. So we know that the procedures that we're using with the kiddos are effective in teaching them the skills they need to be independent and successful in life. So with that, we have our RBTs, BCABAs, and BCBAs who will be providing that therapy. So an RBT, that is our registered behavior technicians. These are the staff that are going to be working one-on-one directly with your kiddos. They are that frontline staff. They are the ones that are face-to-face with the kiddos every single day, running those programs, collecting the data that can then be reviewed by either the BCABA or the BCBA. So a BCABA, that's the Board Certified Assistant Behavior Analyst. BCBA is just a Board Certified Behavior Analyst. So with that, to be a BCBA, it requires a master's credential. To be a BCABA, you just need a bachelor's with some additional schooling. And then for an RBT, you just need a high school diploma and then some additional 40-hour training and modules that you have to complete. So a BCBA, they will be the ones who are in charge of your kiddos therapy. They will be the ones running those parent training sessions, maybe teacher training session if that's what we're focusing on. Designing the programs, looking at that data, and making updates as needed, changing protocols and everything to make sure that our kiddos continue to be successful. A BCABA, they're kind of that in-between position. So they are able to do programming to make those decisions, develop new protocols while being actively supervised by a BCBA. And they may also, too, work directly with the kiddos. Being a BCBA, we can also work directly with kiddos, but typically at this point, our focus is more on the programming and supervising the direct staff working with the kiddo than us directly being the ones to work with the kiddo. So lastly, where does this ABA occur? Basically, the way we like to say is that we go where the behavior goes. As long as the site lets us in, we can work on stuff there, and as long as the insurance approves it. So commonly, the sites that you'll see ABA therapy delivered, it's going to be in the school, in the clinic setting, in the home setting, or out in various community settings. That being said, there are certain regulations that insurance has put in place that allows into certain settings or not. For example, in general, insurances don't like us in the academic setting. So it's always more difficult to try to get hours approved within the academic setting because often the way insurances view it is that the school should be providing those services, not them funding an individual provider to come in and provide those services, which not the most realistic, but that's where we're at. But typically in the home and in the clinic settings, those are a lot easier to get approved because those are more natural environments. Being in the home, while being in the clinic is a lot more therapeutic of an environment to really focus in on those core skill deficits that we're working on. As far as community settings go, that's going to be another insurance regulation that whether they do or don't let us into certain settings. Like, for example, other therapies, camps, sporting events, those are typically harder to get approved for us to provide ABA therapy in those settings versus maybe going out to, a local park or a playground or the mall and those type of settings to work on those various skill deficits. So once we start with a new kiddo, one of the first things we do is that we take this ABC data. So that's going to be a term we use all the time in the field of ABA. So that's a 3-part analysis. With that, we're looking at the antecedent, the behavior itself, and then the consequence. So within the field of ABA, antecedent simply means what happened before the behavior occurred. Consequence means what happened after the behavior occurred. Whether the good, the bad, the ugly, consequence just means it happened after the behavior happened. While looking at the behavior itself, we want to make sure that the behavior that we're seeing, we're able to objectively define it. So that means if I'm going in to take data on this behavior and then my RBT goes in to take data on the behavior, we're both taking data on the same behavior because it's been defined that well. And that we know that we're both looking at the same thing, which tells us we can trust the data all that much more. So once we have this, the ABC data, we look at that and that gives us an idea of what the function of this behavior may be. So that's a big thing with ABA too, is that we always look at what is the function of this behavior. So once we know what the function is, then we can work on teaching an appropriate replacement behavior to engage in instead of engaging in that maladaptive behavior. It should be noted that with the ABC data, with that, we're focusing mainly on those maladaptive behaviors that we want to reduce, and not so much the skill acquisition skills that we want to see increased. So with this, we're focusing on those maladaptive behaviors that we want to see reduced. And once we know the function, we can teach those appropriate replacement behaviors. So that we know, we do say that there are 4 main functions of behavior that, first, all behaviors can be broken down to. So with that, it's attention, which we know, attention, the good, the bad, the ugly, so that phrase again, whether it's that positive attention, good job, way to go, Betty, or that negative attention, those reprimands, hey, stop that, don't do that, I don't like the way you put hands on your friend. Any of those examples, it's attention. Social media, prime example of attention maintained behavior right there. Also, there's going to be to escape or avoid something we don't want to do. This happens all day, every day. We engage in behaviors to try to escape or avoid, procrastination, delay, all of that. Totally normal. Also to gain access. So that means trying to gain access to something not currently in our possession. One of those biggest things we try to gain access to all the time is going to be money. For kiddos, that could be a preferred edible, a favorite toy, the iPad, the tablet, maybe going to a favorite park, going to Disney, just gaining access to something they don't currently have. With that, it could be a person, a place, or stimuli or object, too, that they want to gain access to. Then the last one that we talk about is that sensory automatic reinforcement, which basically means you do it because it feels good. Some common examples of that may be, you see people do the hair twirling, the various stereotypic behaviors our kiddos may engage in, going to get a massage. We do all those things because it makes you feel good, so that's why you do it. I always like to talk about that there is this 5th function of control. So that one within the field of ABA hasn't been scientifically proven yet to be a function of behavior, but working with kiddos, if you know, you know. You can tell that sometimes the function, it is purely control is what the kiddo is trying to get in the moment, which seems to be that combination of escape, avoidance, and attention at the same time. With that, it should also be noted that oftentimes the behaviors have multiple functions all at once. That I could be, let's say I just went up and threw my pencil across the room because I wanted to escape the work in front of me, but also want to gain the attention of the teacher. I'm kind of feeling bored, maybe want to get into a little battle. So I'm doing both at the same time. Also, behaviors may start as one function, but then get maintained by a different function. I threw that pencil originally just to get out doing my work. Then all of a sudden, all the kids in class are laughing and looking at me. I have the attention of everyone. Oh, now I'm really amping it up to keep that attention going. So once we've collected our ABC data and we've hypothesized what we believe the function of the behavior to be, we then go in and we intervene on that behavior. So that's when we make those specific protocols and procedures to follow to teach our kiddos appropriate replacement behaviors to engage in that get them that same function instead of those maladaptive ones. So for example, as with my previous example on the last slide with throwing the pencil to escape doing that worksheet you don't want to do. Well, instead of throwing that pencil, we can then work on teaching to appropriately ask for a break. Simple. Both of them get you out of the task, but by vocally asking for a break that can be granted in the moment, that's that appropriate behavior that we want to see instead of throwing a pencil across the room. So the goal is always that our clients learn these appropriate behaviors to engage in to get their needs met instead of engaging in those various maladaptive behaviors. And with that too, we focus on what we call the socially significant behaviors. So like I said on the previous slide, all people engage in maladaptive behaviors. No one on this planet is perfect who does not engage in any behaviors throughout the day. So what we're focused on with our kiddos is those socially significant behaviors that truly make our kiddos, in a way stand out, or that impede them from doing something that they want to be doing, that impede them from participating in a group classroom, that impede them from joining that basketball team, that impede them from being able to be left alone on the couch for 2 minutes. All of these type of things that just impede them from being independent and successful in whatever environment they happen to find themselves in. So with that too, I just want to make a point that with us focusing on those socially significant behaviors, that we focus on the behaviors that benefit the client and not really those around. So yes, it may be annoying that little Johnny over there, he's tapping that table. He's tapping that table all day long. It's annoying everyone. But when it comes down to it, he's still answering, he's still responding, he's still completing his work. If someone asks him to stop, yeah, he'll stop in the moment and then maybe 10 seconds later start up again. But in that moment, tapping the table, that's not going to be something we really focus on too much. Because we want to really focus on, like I said, those socially significant behaviors that impede versus those more annoying behaviors. So on the previous slides, we focused on different methodologies that we have for reducing those maladaptive behaviors. So on this one, we're going to turn our focus onto increasing those skill deficits that a lot of our kiddos may have. So with that, the specific domains that we can address, like I said, are going to be regulated by the insurances. So insurances year by year are really cracking down on what is and isn't allowed for us as ABA providers to actually teach our kiddos. So with that, they want to make sure we stay within our competence, that we're not, going into maybe that's too much of a speech therapy goal that is better addressed by an occupational therapist than an ABA therapist. And that we're addressing what are considered to be the core deficits of autism and not addressing a behavior or skill deficit that's actually related to maybe a different diagnosis or disorder, but not to autism specifically. So, once your kiddo gets started in ABA, you'll probably hear the phrase, or if you ask your insurance, about the core deficits of autism. So those are going to be the 3 main domains that insurances let us intervene on, and that they will approve us to actually make programs for to teach these skills. So that's going to be social communication, social interactions, and then reducing those repetitive maladaptive behaviors. So like I said, we spent the past couple slides talking about those repetitive maladaptive behaviors. So now we're going to talk about more of those social communication and social interaction. So as far as the communication, that's going to be communicating with others, expressing your basic wants and needs, having conversations, maybe initiating play, answering questions in a group, telling your parents how your day was, letting them know what your plans are for that weekend. All those different types of communication. And with that communication, whether it's vocal, as I'm speaking right now, it could be sign language, it could be a communication device, it could be that picture exchange system, different means of communicating. With that, even vocal communication, there are several forms of nonverbal or non-vocal communication. It's kind of giving someone the look or those hand signals, like, where's my hand? There we go. Gesturing, like, come here. Or, all those different types of means of communication that often the kiddos on the spectrum, we need to teach those specifically. The next one's going to be those social interactions. So whether that is allowing peers to play within 5 feet of you with the same toy, giving up a toy that you like, sharing, turn taking, game skills, making and maintaining friendships with others, accepting being around non-preferred persons, all these different social skills are things that we can address. So as you can probably tell, that's a very limited list. So like on this list, for example, you don't see academic skills, you don't see vocational job training skills, you don't really see self-care or daily living skills on here either. So as far as insurances are concerned, that yes, those are important skills to have, but those domains can either be better addressed by other services, or because they don't address a core deficit of autism, that's not covered for ABA therapy. So there's always ways we can work on these skills, if we really focus on the desensitization aspect of it. Let's say we have a kiddo that self-care, they don't want to get wet. They hate water. So in that case, we can work on desensitizing them to the water, which would inadvertently let us kind of work on maybe, those hand washing, maybe washing face, depending on location and the age of the kiddo, basic showering type skills, which that would be a lot of the parent training as well. But that is something that insurances do let us do, is that within the domain of parent training, we can pretty much focus on anything, which is cool. As long as we have the parents and the caregivers involved, what we can focus on and teach the kiddos is a lot more open than what they allow us to just kind of work directly on with the kiddos without the parent or caregiver present. So when requesting the ABA hours, something we always look at is what is the medical necessity of ABA for this kiddo. So with that, it's funded by insurance, so there has to be justification in us requesting these ABA hours. So some things to look at are going to be the kiddo's history of ABA and the other therapies they've received. For example, if we have a kiddo come in, they're 10 years old at this point, they've been in and out of some different schools, still have some behavioral issues to work on, but they've, been in and out of ABA therapy for the past 7 years across different companies, made some progress, still a couple things to work on, had the speech therapy, the OT, the PT, master out of all of those therapies, and then they come to us. So at that point, just based on that kiddo's history and age, we're not going to get full-time hours for that kiddo. Very unlikely that we would get those full-time hours, even if we requested them. So at that point, it's looking at more like maybe a 10 to 15 hour a week type kiddo, just focus on those additional skill deficits that may have cropped up, do a lot of parent training so that way the parents and caregivers know how to effectively teach these skills, and then fade back out. The age of the client is going to be a big factor, and also the specific diagnoses that the kiddo has. As I said on previous slides, if the kiddo has multiple diagnoses, that the insurance can say like, hey, those behaviors, those skill deficits, that's not related to the autism diagnosis. That's more related to, their other ODD, their ADHD, their cognitively delayed, XYZ diagnosis. That can be something. Also, the age of the kiddo, especially the longer they've been in ABA, insurances are going to want us to cut back the hours. ABA is not meant to be a lifelong therapy. It's meant to be more like the other therapies, the speech, the occupational, the physical therapy. We get the kiddos, see them for a couple years, and then we fade back the services and promote their independence in society. So I think that's something that always needs to be kept in mind, is that yes, ABA, it's great, it's effective, but it's not meant to be there forever. That we're just meant to jump in, teach the kids the skills that they need, so that way they can be taught by others additional skills in life, and not be so reliant on having that ABA therapist with them throughout their day. Another thing that's going to affect how many hours we get is going to be the specific insurance that's funding the ABA, also the locations that we're trying to request those ABA services in. Different funders have their different rules and regulations based on the history that the kiddo's been in ABA, different protocols and procedures tried, the location we're requesting services in. That will regulate how many hours we can or can't get. As I saw in previous slides, the location is very important because there are some insurances that they just will not let us in the academic setting. It's not going to happen. Even with all the justification and the behaviors and, hey, the kiddo can't safely be in an academic setting without someone with him, depending on the insurance, they can still say no. As I said as well, clinic, home setting, typically easier to get those hours approved within those settings. Something else that we look at when requesting hours, part of that medical necessity, is going to be that rate and severity of the maladaptive behaviors. So the higher intensity, the higher severity, the higher the frequency and duration of these maladaptive behaviors, the more justification there is for ABA hours. But the less severe behaviors that happen less frequency, less intense, that's going to result in less ABA hours, which is great. We're not trying to get all the kids full-time hours. We're just giving them what they need to be successful. And then on the opposite side of that, we're going to be looking at also the skill deficits they have. Kind of the more skill deficits a kid has across these various developmental domains, the more justification there is for ABA hours in that aspect. Something that insurances are really kind of making a shift towards is that they're focusing more so, it seems like lately, on those maladaptive behaviors versus the skill deficits. So in general, kind of the more behaviors that the kiddo has, the more intense they are, that will more easily get ABA hours versus just the straight skill deficits with a kiddo who has minimal behaviors. And then, as I said too, it's going to depend on those comorbid diagnoses. So, we have little Johnny who he has his meltdowns daily when presented with non-preferred tasks, Is that the result of the autism? Is that the result of ADHD? Is that more so the result of his intermittent explosive disorder? Which one is kind of that maintaining variable for this behavior? Also something that gets looked at. Just always keep in mind when we request hours, it's based on what is the medical necessity, what does this kiddo truly need, and not based on, oh, well, convenient, this would work out best for our schedule, and oh, hey, this would work out best for the parent's schedule. It's based on what benefits the kiddo, what do they truly need to be successful in life. So, and to wrap things up, I wanted to end on talking about the feeding and discharge process with ABA. So however many hours we know we have to start, if we go for the full 40 hours a week, 30, 20, 15, 10, 5, there's always going to be a fading process to that. Because we know going from 40 hours a week down to nothing, 20 hours a week down to nothing, even going 10 hours a week down to nothing, that can have a negative impact on the kiddo if those services have not been effectively faded out correctly. As I said previously, on the last slide, ABA therapy is not meant to be a lifelong therapy. There is an end in sight. So our goal is to how do we fade back the ABA services to the point of discharge while ensuring that the kiddo has the skills that they need to be successful in life and that they can navigate these different situations that maybe we did not directly teach, but we gave them the foundational skills that they can still navigate and be successful in those different scenarios that they may encounter in life. So how do we determine when to fade back ABA services? Many factors to this. One is going to be based on kind of the family's schedule and their foreseeable future. With TRICARE specifically, that's going to be a military one. Oftentimes, families may only be in the area for 2 years at a time. So in that aspect, we may be really trying to focus on what are these skills and behaviors that we can make progress on and teach within this 2-year period. Others, we may know like, hey, this kiddo, they're moving out of state in 6 months. This is all we have with them. They have other kiddos that they are staying here. They have no intentions of moving. We could see this kid for life if need be, which we wouldn't do that, but the option's available. So a lot of it's going to be based on that. And then also, what does the insurance allow? Because the more we work with kids, the insurers just want to see those changes and updates. But if we've kind of just maintained that same status for a while, they're expecting us to fade back those hours. So kind of what happens once that's started. So here at Puzzlebox, we actually created our own type of fading program where the therapist will take data. This data is evaluated by the BCBA and kind of gives us a snapshot of what would this kiddo be doing without ABA therapy. So we know if the kiddo's doing well, justification to fade back hours. Kiddo's not doing too well, okay, if the hours are staying the same, we're not fading back yet. So how does a discharge happen? Like I said, ideally a discharge would happen based on a fading process to be very systematic. Everyone knows it's coming. We end on the good note on the day that we plan to, and everything's great. The kiddo goes off and is successful in life. As we know, that doesn't always happen because life happens. As I said, families move, insurances change. We've had kiddos before that they had one insurance, and then all of a sudden, as of January 1st, insurances switched. The new insurance didn't cover ABA, so we just had to drop the kiddo. Completely unfortunate. We have families move, based on different situations. There's been situations before I know of that ABA companies have shut down and just their clients are it's kind of left there going to find different providers. So ideally, though, the discharge, it is planned. It is very systematic in the process of how it happens. Because we want the kiddos to be successful, and research has shown that you have to fade things out systematically so that way we set the kids up for success. With that, the more we fade back direct hours with a kiddo, that's going to be more of a focus then on those parent and caregiver training goals. Because as I said, ABA therapists, we're only going to be there a couple of years, but the parents, caregivers, you guys are there for life. So then we're going to train you guys on how to effectively implement these protocols and procedures, give you some troubleshooting ideas, tips and tricks, so that way you can carry that on. And some things that come next. Something that I've been recommending more and more to families once they do discharge from ABA, as the kiddos get older as well and really enter those puberty and teenage years, looking for a mental health counselor, looking for someone to talk to. Because just growing up as a teenager is hard enough for the kiddo and the family in general, but then you throw in the autism and then you throw in the other diagnoses, various physical, mental illnesses, X, Y, Z. It's hard for everyone. So really, I would recommend that family therapy for everyone. It makes, the family go, talk about the issues, ensures everyone's on the same page, is that continuation of a therapy and an aspect, and just gives, if nothing else, someone to talk to, because it can be hard. So that's always what I would recommend is, continue on, seek some additional type of therapy. There's all these social media groups out there with support groups to stay with talking to other people who are dealing with autism as well, because it can feel isolating, it can be hard. So you want to make sure that you do have that support group to keep that success going, and not that we discharge the kiddo from ABA, things do well, but then it all just takes a 180 turn and doesn't go well afterwards. So as always, I'm going to end with our 3 questions that we ask. So for our current Puzzle Box Kaleidoscope Interventions families, you just have to answer these 3 questions, turn them into your site, and then you'll get credit for attending this parent training. So question number 1 is going to be, what does ABC stand for? Number 2, what are the 4 common functions of behavior? And number 3, what are the core deficits of autism? So I said, just get these questions answered. You can turn them into your site to get credit for this parent training. And as always, if you have any additional questions, concerns, anything that you'd like to talk about, recommendations of future parent training videos you guys would like to see, please reach out and let us know. And as always, have a good one.